And what I'll be doing today is that I'll be presenting on a previous presentation of mine that was initially presented in 2019, which was my own journal review regarding the controversies regarding perioperative beta blockade. So I'm not sponsored by any generic or branded drug makers. So this is basically a recycling of my previous slides. In fact, I decided to not even change the slides to a widescreen format. Initially presented in 2019, and I updated it slightly after doing a little bit of literature review. So the issue is when you have a clinical scenario, when you have a patient at risk of a cardiac event in the perioperative period, what should you do? Should you give the patient a beta blocker, or should you send the patient for an angiogram followed by intervention of some sort, or should you just bite the bullet? And let's see what were the guidelines. And this was the guideline from the ESC, from the European Society of Cardiology, and this was the guidelines in the pre-2012 period, in which they recommend beta blockers in those who have known IHD or myocardial ischemia, and they recommend in patients who are going to undergo high-risk surgery, and they even say that you should consider it for those who are going to undergo intermediate risk surgery. Okay. And at that time, they gave a class 1 recommendation, which means that you must give it. And this was based on actually relatively low level of evidence at that time, which they consider as a grade B and grade C evidence. And what did the ASA say on the American side of the Atlantic Ocean? And they said that they gave a class 1 recommendation, of course, for those who are already on beta blocker to continue it. And they also said they should be given to those who are going to undergo vascular surgery, or those who are deemed to have a high cardiac risk based on the finding of perioperative testing. And they gave class 2A recommendations to start beta blockers in those undergoing vascular surgery in whom preoperative assessment identifies cardiac disease. And they say that you should probably also start for those who have a high cardiac risk, defined by the presence of more than one clinical risk factor. This they gave a level of evidence B, and the typical clinical risk factor index that we use is the revised Lee cardiac index. Okay, and they also said that probably you should start if you identify cardiac disease or high cardiac risk who are going to undergo intermediate risk or vascular surgery. And these guidelines were actually based on one of the landmark trials, which was the decreased family of trials. And this decreased family of trials was actually conducted by Dr. Poldermans, who was a professor at Erasmus University in the Netherlands. And ironically, he was also the chair of the ESC's Perioperative Task Force, and covered the issue of perioperative beta blockade. And since he was among the researcher and he was among the task force, and his research more or less dictated the guidelines in the AHA 2007 and ESC 2009 guidelines. And what were the family of decreased trials that he was involved in? So there were 5 decreased trials, and the initial landmark trial was the decreased 1, in which his conclusion was that in high-risk patients undergoing non-cardiac surgery, perioperative beta blockade with bisoprolol significantly reduces cardiac death and MI in the short and long term. So basically, just you see high-risk patient, you just start lah. And then after that, he also follow up with a further 5 studies, all in the decreased family. And in the last decreased trial, so he said that his conclusion was that in high-risk patients with extensive stress-induced ischemia, in which so you have a patient who was tested and known to be positive for stress-induced ischemia, then he says that coronary revascularization does not produce additional reduction in death and MI and delayed surgery. So in this kind of patient, his conclusion was that if you have a patient that has stress-induced ischemia, rather than sending the patient for revascularization, it's good enough for you to just start the patients on bisoprolol. So what happened next? So after several years, there was actually serious doubts over his research, and Erasmus University actually conducted a formal investigation, and there were reports made in 2012 and 2014. And these are some of the quotes from the internal investigations, which if you have doubts, you can actually look for them online, and somebody has leaked them. So and it has been shown that the investigators deemed that there was a failure to preserve essential source documentation, and they found that the data that was stored was not actual data but just the interpretations. And then there were actually changes in the study designs. They actually did not even record the actual medication use, and because of that, the board found that they couldn't actually trust the decrease 2 to 4 study findings, and they felt that the study was based on fictitious data. However, the investigators actually did not investigate decrease 1, because by the time they started the investigation, decrease 1 was actually more than 10 years old. But there were some informal levels of irregularities, like they couldn't trace the identities of the patients, and there were so-called study members who denied participation, and there was differing data in the source. So what happened when they found all this? So Poldermans was actually removed from the Erasmus University, but what happened was that his studies were still being quoted in the subsequent ESC guidelines in 2014. In which this in the 2014 update to the guidelines, they say that in patients, so this is AHA. AHA, they say in patients with intermediate or high risk myocardial ischemia, it may be reasonable to begin perioperative beta blockers. So it's still a class 2B recommendation, a bit lower, and they have lowered the level of evidence to class C. But these guidelines still quoted the findings from Polderman's studies. And the same thing happened with the ESC. So these were the ESC guidelines. They were still quoting the relevance of using beta blockers, but and some of the studies were still quoting decrease. For example, like the one up here, Mangano. This one actually did not involve the decrease trial. It was an RCT, but in this trial, when they compared beta blocker, they actually did not account for the number of in-hospital deaths. So they only looked at patients who survived outside of out of hospital, and there was a difference in the protocol in the usage of beta blockers and ACE inhibitors, where there was a noted difference in mortality. And here in the Angeli and the McGorry meta-analysis, they actually included the decreased family of trials. And with Lindenauer, it was actually a retrospective study that did not identify the indication of the beta blocker. And then subsequently, the 2014 ESC guidelines also quoted London study, which was a retrospective study that actually combined initiation, new exposure, as well as withdrawal together. So there's no way for you to tell whether beta blocker actually made a difference, or if it did, was it because of its initiation pre, or is it a new exposure, or is it because of continuation? And weirdly, they also excluded those who died on post-op day 0 and 1. So it makes the findings less powerful for you to actually see what are the actual findings. And anyways, when they wanted to recommend beta blockers, they did note that the number needed to treat for mortality as regards to use of beta blockers is actually quite high, 241 patients. And they noted that there was a lower number needed to treat in patients who had a higher RCRIs. So in patients who had a revised cardiac risk index of 4, then the number needed to treat actually went down to as low as 18 patients. But the only problem here is that it was mainly a retrospective study. And the problem with Wallace, even though it was an RCT, it was actually much smaller than POISE, which I'll come to in a bit shortly. In which POISE employed 8,000 patients as compared to Wallace, which only employed 200 patients. So what was the main study that contradicted decrease later on? The main study that contradicted decrease was actually the POISE 1 study, which was headed by Devereaux's group in Canada. And what they did was they started extended release metoprolol on the day of operation, 2 to 4 hours pre-op, as long as the patient fulfilled their criteria. And what they gave was they aimed for about 100 to 200 milligram daily of extended release metoprolol. So there was a lot of criticism regarding this study protocol, because they felt that extended release 100 to 200 mg daily is a high dose, and and therefore cause more harm to the patients. And the counter argument from the POISE group was that whether the extended release metoprolol had probably had a similar bioavailability compared to immediate release of 25 to 50 mg 3 times per day. And they also argued that if you want to start beta blockers, if you do not see a good reduction in the heart rate, then there's probably no point in starting the beta blockers. And ironically, even though they said that the POISE 1 study was harmful, the heart rate reduction was only about 7 beats per minute in POISE 1 as compared to the even higher purported decrease in the heart rate in decrease 1 and decrease 4 studies. And there was also arguments suggesting that atenolol or bisoprolol was probably superior to metoprolol as regards to the protective aspects to the patients. So because of all these, so maybe you don't know what is POISE 1, but I'll come to the main findings of POISE 1 later. But before that, we go to Buri's meta-analysis in 2013. So Buri's group was among the few that was a bit outraged by the fact that decreased family was probably based on fictitious data, and they did a new meta-analysis in 2013, and they removed all the decreased family of trials. And you can see POISE has a very big weightage in this meta-analysis because they employed 8,000 patients. But overall, you can see from this forest plot, the overall findings do favor control, which is not using a beta blocker. The only one here that seemed to favor beta blocker was Yang's group. But as you can see, the incidence of events was only 1 out of 51 patients as compared to 0 in 51. So it's actually quite a underpowered study. So at that time when I presented this presentation in HKL, I was looking at, so is there something new after the 2014 ESC guidelines and AHA 2014? So actually there was some other aspects of evidence, like the study by Park's group in Korea, if I'm not mistaken, where they did a retrospective study in patients who were already revascularized but no evidence of heart failure. So they looked at whether the new use of beta blockers helped to do anything for the patients. And in this particular study, I'm not sure whether you can see it or not, but you can see there's nothing here that's less than 0.05. So basically, there's no proven benefit of new initiation of beta blocker therapy. And then we go back to POISE. So this actually, so what was the findings that were highlighted with POISE? So POISE found in their initial study of 30-day follow-up was that there was a reduced number of cardiac events. That's also a significant finding in probably all the other studies as well. However, POISE 1 noted that there was a high incidence of mortality overall, and a lot of the mortality were all non-cardiovascular related, as relating to stroke. So when they initially published their study in 2013, it was the main contradictory finding to decrease. And afterwards, in 2018, they did finally publish their 1-year follow-up results. So in their 1-year follow-up results, you should also showed the same thing, where POISE, where the initiation of beta blocker seemed to reduce the cardiovascular mortality, but increased all-cause mortality, especially as related to stroke. So as you can see here in the 1-year all-cause mortality, initially there's not much of a difference in the immediate perioperative period, but afterwards you will see this separation between metoprolol and placebo, where there was a higher all-cause mortality. And when you look at it, it's mainly non-cardiovascular. And when you look at 1-year myocardial infarction, I think it's an expected finding that patients have less incidence of MI. But look at the stroke. So even though you have less number of MIs, you have a high number of strokes in the patients who received metoprolol versus placebo. So when Devereaux was trying to counter-argue regarding the study design, like I said before, they felt that if you want to start beta blocker for its purported benefits, then obviously you need to overcome the sympathetic activation and you need to see some level of heart rate reduction. So their argument was that if you use a smaller dose and you don't see the heart rate reduction, then what's the point? And they also found that in their 1 year follow-up that a lot of the hypertension actually occurred in the ward and probably late being recognized. So because of that, you get the strokes. And they found that actually a lot of the patients also developed sepsis. And their idea was that probably because of the reduced cardiac output effect of beta blockers, probably these patients develop bowel ischemia and subsequent bacterial translocation and sepsis. So along with all the previous people being outraged, so Andrew Foy was among the cardiologists who commented on the whole controversy, and he had the opinion that if somebody needs surgery, they should just go get surgery. There's nothing much you can do. And Cole and Francis was among the few authors who were so outraged. I can't remember which journal they made an article, but it was so inflammatory that the article had to be redacted in an effort to reduce the anger from all the other academicians around the world who felt that we probably caused more harm than good by perioperative beta blockade. And in fact, when Blesberger made a systemic review, they found that overall there's probably no benefit at all in initiating beta blockers in non-cardiac surgery. So if that's the case, is it possible to just go for surgery rather than do anything? So this is the CUP study in 2004, actually before POISE, before POISE. And in this study, they actually looked in the setting of vascular surgery. Not really, I mean, still non-cardiac, but vascular surgery is among the highest cardiac risk surgeries. And what they did was they looked at angiography based on clinical assessment or stress testing and tried to see whether randomizing to revascularization helped or not. But there were some study designs that made the findings less useful. Number one, they actually excluded those with significant left main coronary disease. Those with severe AF less than 20% were excluded. Those with severe AS were excluded. And in fact, when they screened the patients for the study, only 9% of the original cohort were eventually randomized to revascularization or straightway to surgery. And overall, there is no difference in outcomes. However, they did a subsequent subgroup analysis for those with abnormal stress testing and those who were revascularized. They showed improved long-term survival. So this was the subgroup analysis. So as you can see, if you have proven anterior ischemia and you not revascularize, they kind of fall off a cliff and die much earlier, as compared to those who had ischemia and were revascularized before undergoing vascular surgery. You see that there's a significant difference in the mortality, overall mortality, and they found that more or less you have a difference in your mortality up to about 5 years after the revascularization. So what about just do prophylactic angio? No need to think, just do prophylactic angio. So in this one was Monaco's study in 2009 involving AAA surgery. And in this study, there is proven benefit of just of undergoing a prophylactic angiogram followed by intervention. Okay. How about Illuminati's group? In this time around, instead of AAA surgery, but for carotid endarterectomies. So here that for those who undergo coronary angiography followed by intervention, there is quite a significant difference in the mortality rate. Okay. So is there anything new? That's new as compared to my previous presentation in 2019. So let's go back to the ASC guidelines, because AHA, as far as I checked, there was nothing new. But the ASC guidelines did publish something new in 2020, last year lah. The ASC non-cardiac surgery guidelines. But if you compare, actually the class and the level class of recommendation and the level of recommendation are exactly the same. The only difference here, if you try to look into the literature or you try to look into their wordings, they never mention Poldermans, and all the studies that previously quoted Poldermans were redacted. However, as you can see, despite the removal of all that evidence, there is no change much in the recommendations. So I tried to see whether there's any study that's new that's being quoted by them. And there is one study that's new, which is a retrospective study by Fredel and his colleagues in 2015, which has a retrospective study among American veterans. So looking at beta blockade and non-cardiac surgery. However, this study again is hampered by the fact that it's a retrospective study that did not look much into the details of the beta blocker use, meaning that you don't know what drug was given, you don't know when it was given, whether it was given pre or post-op, or whether it was studied at home, or whether it was studied in the ward. Nothing. It's just looking at the records and then looking whether beta blocker was ever given, and then they were included. So what was the finding in their retrospective study? It's quite interesting because in those who were given beta blockers, you have a less risk of mortality if you have a very high number of risk factors. Yeah? But if you do have only a low number of risk factors, like 1 to 2, your mortality risk with beta blocker or no beta blocker is about the same. But if you have 0 risk factors and you are started on beta blockers, you die more. There's a higher risk of mortality. So that is one interesting result. So when I presented last time, I didn't actually put all the headlines that were published in academia and the news. But this time around, I'll just include some of the headlines of people talking about this perioperative beta blocker debacle. So this was an article that tried to justify the fact that the ESC did not retract the recommendations despite the allegations against the decreased family findings. And there were a few others articles looking into learning about learning what we can do in the future to prevent such a thing from happening again. So earlier I showed you Guri's meta-analysis, which they call as a meta-analysis of secure trials, and they had pretty strong words regarding the ESC and AHA guidelines, saying that they should retract their recommendations without further delay. And they even made allegations that that we were probably causing mortality in our patients. And one of the things that we can look at as regards to perioperative beta blocker blockade is that sometimes in medicine we get excited because we are looking for a magic bullet, we want to prevent MI. Is there a real way to prevent MI? So we tried to look for that magic bullet that works, and then suddenly when Decrease was published, everybody, wow, this is the ultimate drug, and everybody thinks that we should start beta blocker. And in fact, at the time when Decrease was published, especially in the United States, they made beta blocker as an indicator of quality. So let's say if you do not start beta blocker preoperative, you are doing something wrong, and you are basically liable. And then when we look back, suddenly it turns out to be that the other way around has been more or less the truth, and we have been causing more harm to patients. And this is not the first story, because as you can see in the quotes here, so we thought there were many instances of where initial medical therapies turned out to be more harmful than good, like tight glucose control in the ICU, the use of activated protein C, or even in the further past, you would hear about use of hormone replacement therapy for postmenopausal women. And even I think you can even, to an extent, you can say the same thing about what's that thing, glutamine in sepsis. So you can see all of these have more or less gone away. But especially with the ones quoted here, you see there's actually added harm. And even HRT in postmenopausal women actually caused more harm when we thought that physiologically it would be good for the women. And basically the lower paragraph just shows how, because we wanted to look for that magic bullet, so when we see something that's so-called good, we just straight away take it up and say that it's mandatory for all. So what's the main takeaway? Main takeaway is do no harm. So as regards to cardiac, non-cardiac surgery with cardiac patients, maybe risk stratification is all you can do. Maybe revascularization is good for vascular patients, but if you know anything about our local setup, trying to send patients for a prophylactic angiogram before vascular surgery is not something that is logistically feasible. And that's why in our vascular centers, patients do not undergo routine angiogram once they are scheduled for open AAA. So, but of course, with all the retrospective studies showing some benefit, maybe beta blocker is helpful in those with high risk RCRIs. But before we can really commit to it, probably we need stronger evidence, and probably we need better RCTs with a high number of patients as powered as points. Maybe with a different protocol, and maybe we can come to a conclusion. But I don't think anybody has the appetite to do it. So always be careful with what you read. You may think that the guideline bodies are the authorities, but as you can see, even with guideline authorities can be wrong at times. And do not make assumption that the lab translates to the patient, or that findings in one clinical scenario where beta blockers are proven beneficial in heart failure or HD. Don't think that it can translate to another scenario, for example, in patients who are undergoing operations. Any questions? I will agree. I mean, in the past, here pun I remember a time when we some patients were started preoperatively in the GA clinic, but I think until we see real evidence that it actually causes benefit in the high RCRI, I don't see a strong enough evidence to start now. In that sense, I don't agree with the guidelines saying that still putting it as a 2B lah. Hemodynamic is probably best. I think because of course the main physiological rationale is maintaining this so-called demand supply balance. But the perioperative patient is not the same as the patient who went an MI, because the one who went an MI, the MI because of a plaque. The one who undergo surgeries, the main reason why they get ischemia is because of supply demand mismatch. But if you give them beta blocker, then you reduce the cardiac output. Then of course you protect the heart, but you're gonna compromise everything else. Actually, there's a lot of studies looking into if patients are already on beta blocker. I agree that the main evidence so far suggests maintaining it, because cessation of beta blocker in those who are already on beta blocker increases cardiac events. That one memang proven. I agree with that. I think if the issue is you want to maintain balance during the perioperative period, the most stressful is intubation, extubation. So if that's the case, then you may want to start as smaller, just to control the hyperdynamic response to intubation. I think that will be the practical. The practical is do nothing. That will be the main. We thought we could do more by doing something, but it turns out just doing nothing is probably better. And just like Andrew Foy said, just live with it and undergo surgery. I mean, of course, and this is coming from an American cardiologist, where in the States you have easy access to cardiology services. So from somebody who in the States, you need surgery, you can probably find a cardiologist anywhere. As compared to here in Malaysia, where if you want cardiology services, we have to go through medical. They need you need an appointment and things like that. And even in a setup like in the States, people disagree with trying to do anything for those with ischemic heart disease, unless if they are already clinically indicated based on the previous guidelines. But of course, if you look at those other studies, like the vascular type of surgeries, like the CARB or studies like that, I mean, there's proven benefit, but again, it doesn't translate to our local setup. How are you gonna get somebody who's gonna undergo AAA to get a routine angio and then delay surgery? It's very difficult. Unless if the vascular surgeons can like suddenly agree, oh, I see that the aortic aneurysm is now 5 cm, I need to plan for surgery, now I'm going to refer to cardiology for assessment. I'm not sure whether we are near that because even like HKL, you don't have a cardiologist, right? You're still going to have to refer to Serdang or IJN for a proper cardiology assessment, so it doesn't work out.